Yes, ma'am. We are live now, but we will start at sharp 3. So we are live now on YouTube. Yes, ma'am. It's sharp 3. Dr. Anil, sir, we can proceed because we are on live now. We are on YouTube now. You are on mute, sir.
Yeah, please go ahead.
Yes, sir. I am sharing the screen.
Yeah.
Yes, sir. Hope my slide is visible.
Yeah, it's visible.
Yes, sir. I am putting myself on mute. If there is anything, please call my name. I will unmute myself.
No problem. But doctor has to be introduced by you.
No, sir. You will introduce the doctor.
Okay, fine.
Yes,
Can I go ahead?
yes, sir. Yes, sir.
Yeah. I invite Dr. Balamba Puranam to this conducting this meeting. Her date of birth 23rd July 1944. She did her MBBS in 1968 from Osmania Medical College, Osmania University, Hyderabad. She's a DGO and she completed her DGO in 1972 from Kurnool Medical College, Kurnool SV University. Then she did her obstetrics and gynecology MD in 1976, Osmania Medical College, Osmania University. She's the former professor and HOD of the Department of Obstetrics and Gynecology, Osmania Medical College, Hyderabad. She's a former additional superintendent of Osmania General Hospital, Hyderabad. She's also the former additional director medical education, Andhra Pradesh, professor emeritus obstetrics and gynecology, then in the NTR Health University in Andhra Pradesh, former president, FPAI Hyderabad chapter, and at present she is a consultant at Salini Hospital in Barkatpura. She is the vice chairman, AICOG 1998 organizing committee. She was the chairperson organizing committee AICOG in 2011. She is a former president OGHS 2008 and 9. She is the former secretary OGSH 1996 to 2002. She is the chairperson governing body Prajwala Anti-Trafficking Agency. It's an NGO. She is the president Family Planning Association of India, Hyderabad chapter. She is the chairperson, Project Advisory Committee, Indian Institute of Health and Family Welfare, Andhra Pradesh. She is the guest faculty, Awares, Academy of Nursing, Studies and Empowerment of Women, trained all government and private medical college staff for prevention of parent to child transmission, HIV and AIDS. She published scientific papers in national and international journals. She is the member, Medical Advisory Committee to Chief Minister Andhra Pradesh. She is the member advisory committee on surrogacy to the government of India. Dr. Balamba Puranam, please go ahead.
Thank you, Dr. Anil, for the kind introduction. Can I have these slides, Dr. Pushpraj? Yeah. Today we are going to talk about the role of Placental injection in pelvic inflammatory disease management. Previously, this was marketed as Placentrix, and now Corona is going to market it as Placental. And we all know about the pelvic inflammatory disease. The number of infertility cases rising by leaps and bounds, tells us how the Tubal factor has become a big problem for us. And we all know that pelvic inflammatory disease is a disease of upper genital tract. So it is a disease of the uterus, the tubes, and the ovaries, and it can even extend to the peritoneum. So upper genital tract infection is pelvic inflammatory disease, and this was coined originally by the American College of Obstetricians and Gynecologists. And usually they'll have bad discharge, they may have pain, they may have dyspareunia, and then they may have even chronic pain pelvis, which we may have to differentiate between endometriosis and sometimes even malignancy. And very rarely, even tuberculosis can also occur, but that is not included into pelvic inflammatory diseases. So the clinical presentation may vary from mild to very severe, and usually it is a polymicrobial in nature. But the most important ones which we have to think of is Neisseria gonorrhoeae and Chlamydia trachomatis. Laboratory tests are also poor predictors of PID because, if there is cervicitis, you have to take the smear from the cervix and then do a gram negative or gram positive organs intracellular. We have to look for if it is Neisseria gonorrhoeae, and if it is chlamydia, you have to look for giant cells with inclusion bodies, or you may have to do a PCR now. That is available for chlamydia. Can I have the next slide? So what we do usually is when we diagnose a pelvic inflammatory disease. Now here I would like to caution my colleagues that sometimes, when the sonologist does a transvaginal sonogram, if there is fluid in the pouch of Douglas, they always mention to rule out PID. What we have to remember is if the scan is done mid-cycle, with ovulation, there will be fluid in pouch of Douglas. So don't label them as having pelvic inflammatory disease. because it may be a natural physiological ovulation which has caused fluid in the pouch of Douglas. Key symptoms can be aching in the lower abdomen and pelvis, continuous pain, and it may not be very severe. It may be a dragging pain, very uncomfortable for the woman, and excess vaginal discharge with a foul odor, rarely, and pain and bleeding during or shortly after sex. There may be a large erosion which can bleed on touch, which can bleed after sex. That doesn't mean that it is a malignancy, but you have to rule out malignancy too. Of course, when the infection goes up and spreads into the fallopian tubes, the fallopian tubes are damaged, the cilia are damaged. So naturally, it can be, if it is not treated, it can go into a tubo-ovarian mass, tubo-ovarian abscess first, then a mass, and if at all a pregnancy occurs, it can become an ectopic pregnancy, tubal pregnancy, which will be very, very dangerous. And sometimes it's very difficult to distinguish between an acute pelvic inflammatory disease and ectopic gestation, at which point of time, usually we would like to do an ultrasound. And if the ultrasound is doubtful, go for a beta HCG. And even that is doubtful, go for a laparoscopy, diagnostic laparoscopy. And usually if it is pelvic inflammatory disease, you will find pus pouring out of the fimbrial end, and please don't meddle them. You just take a swab for culture and sensitivity and to rule out Neisseria gonorrhoeae and then come out. Don't meddle at all, because if you're going to meddle, you're going to spread it further, and then the woman will land with pelvic peritonitis and rarely even with general peritonitis. So untreated vaginal and cervical infections, usually damage the tubes, and it can cause lots of problems. Next slide. So what happens? We all know, we all have studied pathology. Whenever there is a tissue injury, the cell membrane gets damaged, and then the phospholipids are released, and the phospholipase A2 is released, and it acts on the arachidonic acid. We all know that arachidonic acid is the precursor of all these inflammatory markers, cyclooxygenase, leukotrienes, and then prostaglandins, which can cause inflammation. And we all must have studied, and again in surgery, Dolar, Rubar, Calor, all those things, So all these things will occur, but it is not visible because it is inside the peritoneal cavity. Next. Next slide. Next slide, please, Pushpraj. Can I have the next slide? Yeah. And what are the usual antibiotics management? Usually, we use, if it is acute pelvic inflammatory disease, you have to use IV antibiotics. So our parenteral antibiotics, it can be a ceftriaxone, and oral doxycycline is the best. Doxycycline is now available even as an IV preparation now, so that also can be added. And always we add metronidazole also, either IV or oral. Of course, oral can cause lots of side effects, but still we have to add it. And then gentamicin is also added so that you cover the gram-positive, the gram-negative, and the anaerobic organisms. Now, the alternates can be ofloxacin, ceftriaxone, IM. Then again, azithromycin, the macrolides can also be given. And let us remember that macrolides should always be given on empty stomach, not after food, because it doesn't work. And remember again, macrolides are only bacteriostatic and not bactericidal. Now, the above regimens are not available, then it is going to be a problem, because Neisseria gonorrhoeae, it responds only to cephalosporins, and chlamydia trachomatis, tetracyclines, and macrolides, and anaerobic bacteria, we all know only metronidazole will work for it. As of now, we have only these antibiotics which can be given, because what we do is we cover the gram-positive, the gram-negative, and the anaerobic organisms, expecting that all these things can cause pelvic inflammatory disease. And rarely, after an MTP, which is mismanaged, they can land with the acute pelvic inflammatory disease, especially in septic abortions. Thank God, nowadays we don't see so many of septic abortions, but we used to do in our younger days, we used to see lots and lots of septic abortions, and which used to land these women into chronic pelvic inflammatory disease and infertility. And that used to be a real big problem for us. And then, post delivery also, it can happen. Puerperal sepsis can also cause pelvic inflammatory disease. So all these things we'll have to keep in mind when we are talking about pelvic inflammatory disease and how we are going to treat it. Next. Next slide. Now the problem comes, now we all know WHO has been warning us since a long time, almost since a decade, they have been warning us not to use antibiotics without any culture and sensitivity. Now, can we do a culture and sensitivity in pelvic inflammatory disease? It's going to be a big problem, though we can take a swab from the cervical os and send it for culture sensitivity. Anaerobic organisms very difficult to culture, so we have to cover them anyway. And if you look at all these drugs, over a period of time till 2016, you can see how many antibiotics have gone into the list of the organisms being resistant to them. And we must remember to develop one antibiotic, it takes lots and lots of research, years of research. Now we have seen in COVID era, where the vaccines take 10 years at least to develop. Here they had to develop it in 1 or 2 years and even in 6 months, and that is why we are landing in problems, because the antibodies are waning very fast and still the virus is mutating and then infecting us. The same thing, if the antibiotics don't act, then what are we going to do? Because the bacteria are going to take an upper hand and then the infection is going to become worse and it will become virulent. So when we are using antibiotics, we'll have to be very careful. And when we are using antibiotics, we must have a firm basis and scientific knowledge as to which antibiotic to be used for which organism. And that is why, we always want a culture and sensitivity. And nowadays, if you see the culture sensitivity reports of urine or pus or whatever, you find that it is resistant to so many drugs, antibiotics. So it becomes very, very difficult. And as we are using the higher and the higher antibiotics, more and more resistant organisms are going to develop. And then what are we going to do? So we have to be careful, and it cannot be only antibiotics. So we have to look for something which can be added to the antibiotic so that resistance does not occur. Next slide. So what are the therapeutic gaps? Like just now I have elaborated on the antibiotic resistance, what happens. So the sequelae of PID, I told you, it can be mild infection. You may not even know anything. And when she is being investigated for infertility, you find that there is a tubal block. And you wonder why there is a tubal block. There may not be a TO mass, there may not be anything else. The woman may be having regular periods, but there is a tubal block. It may be most probably chlamydial infection, which is a very, very silent infection. And the treatment is mainly aimed at alleviating symptoms. Suppose the woman has pain, you want to relieve the pain. If she is having infertility, then you want to treat the infertility. And if she is having false menstrual discharge, you want to treat it. So it becomes, symptomatic treatment and not actually the treatment of the disease. So that becomes a big problem. And here you are not going to prevent tubal block by giving them antibiotics. So you need something, which will aid the antibiotics to take care of the bacteria and also take care of the sequelae of the infection. And that is what we are looking for. So antibiotics alone can neither prevent sequelae of salpingitis, like inflammation, fallopian tubes, like I said, or reverse the damage. So therefore, there is a need for therapeutic agent for a comprehensive anti-inflammatory action. We do add painkillers and the anti-inflammatory agents, like naproxen, to so many other things, including the enzymes, serratiopeptidase, but they will relieve the pain to a certain extent. But then what about the sequelae? So we need something, which can be used to prevent the sequelae of this infection also, so that there can be a debridement action of the necrosed tissue and collagenase activity to break the band so that adhesions are not formed. And then, if there is an earlier infection, can we do something about that also? Next. So we want something which will manage which should have an anti-inflammatory action, debridement effect, collagenase activity, and prevent antibiotic resistance. You all must be remembering, even the diabetic foot ulcers, where we need all this sort of thing, not antibiotics alone. Of course, there, you have to control the sugars also. At the same time, you have to give them antibiotic, but also give them something where debridement occurs, and where we are going on dressing, doing the dressings by doing the debridement and other things. But we also need something which may help them out. And here I think this placental extracts may help even in diabetic foot, which though is not included in the slides, I was thinking about it. Next slide. So human placental extract composition, of course, we have to be very careful that it is virus-free, HIV, HSV, hepatitis B, and not only hepatitis B, even HCV should be negative, and it should not have any prions, and it should not have any other viruses also. And each ml of injection will contain 0.1 gram of fresh healthy human placenta, where there is a NADPH, not less than 10 micrograms. And what is NADPH? It is nicotinamide adenine dinucleotide phosphate. It's a cofactor, in all anabolic actions. And you all know that in anabolic actions, we need all the growth factors. And then the total peptides, not less than 90 micrograms, which will help in digesting all the phagocytosing, and digesting all these granulation tissue, and total nitrogen content not more than 0.08%, and benzyl alcohol as a preservative, and water for injection. And you can store it at home. Now, placental extract has been available since a long, long time, and I've been using it because I've been practicing for the past 50 years now. So I know we have been using it in pelvic inflammatory disease quite a lot. And especially when a woman used to come to us, in olden days, we didn't have fertility centers, we didn't have IVS, ET, and all those things. So what we did was we used placental extract injections. Alternate day, we gave them doxycycline, which was available then also. We gave them doxycycline along with human placental extract injections. And almost 50 to 60% became pregnant naturally, So placental extract does act in acute and chronic pelvic inflammatory disease also. Next. Of course, we did see ectopic pregnancies sometimes with the infection. Of course, those days we didn't even have ultrasound also, but still we used our clinical acumen. So the younger generation nowadays is more dependent on the diagnostic tools, but we could use our clinical acumen and diagnose even molar pregnancies without a scan. So those days are gone now. Now everything we depend upon the diagnostic criteria. But even when there was no diagnostic tools, we still used our clinical acumen, and we did use human placental extract. Next slide. So what does peptides do? It has a fibronectin type 3 like peptides, So you all know about fibronectin type 3 like peptides, isn't it? In the premature rupture of membranes, this is one of the tests we perform, because this is what leaks out when the fibronectin is released. It tears the membranes, and that is why the water is leaking, the lacquer is leaking. So the same fibronectin here is going to help in healing the tissue. And then water soluble peptides with corticosteroid releasing factor like activity. We all know that placenta contains cortico-releasing factor. So that is there. And when corticosteroid releasing factor like activity is there, the indigenous, the in vivo, the steroids are released, and that also are anti-inflammatory. And ubiquitin like peptide, which we know is a coenzyme, and it will be an antioxidant. And in the nucleotides, we have PDRN, which is polydroxyribonucleotide. It stimulates the vascular endothelial growth factor, so that the blood supply increases, and naturally when the blood supply increases, the macrophages will leave the place, and then it will phagocytose the debris, and so that the adhesions will not be formed. And I also already mentioned about the NADPH, which is a cofactor for anabolic reactions. And whenever there is anabolic reaction, we all know growth factors have to be there. So it produces growth factors, and so that the tissue healing is hastened. And of course, there are amino acids, glutamate also are added into this. Next. So component contain fibronectin like peptide identified in the drug exits debridement action, which I told you about, by stabilizing trypsin and trypsin-like serine proteases. See, that is what I was talking about, the serratiopeptidase, which we use. And the proteolytic enzymes improve the blood flow by increasing the flexibility of red blood cells, inhibiting the aggregation of platelets, and so it prevents clot forming, And enzyme activity also helps in support of cleansing the tissues and promotes better circulation and stimulating formation of new healthy tissue. And naturally, when the blood flow increases, there won't be any viscosity, because if there is clotting, there will be viscosity. So naturally, proper circulation to the inflamed tissue is brought in, and this will help in opening up the fallopian tubes by blocking the inflammation and necrosis, taking away the necrosed tissue and debris. So reduction in inflammation, increase in proper blood formation, and increase in proper circulation hinders scar tissue and adhesion formation. And that is how you reduce the pain, and you also prevent the blockage of the tubes. Next. So this is the anti-inflammatory effects of placenta. We just now saw how inflammation occurs. So what happens? The phospholipase A2 is inhibited by endogenous steroids, which is produced by the CRF, that is the corticosteroid releasing factor in the placental extract, and its secretion is from the adrenal itself of the woman's body. And then placental action is similar to the body's own CRF. That is what I told you already. Next. So CRF, like peptide and ubiquitin, the functional role is it inhibits the phospholipase A2, thus preventing release of the prostaglandins and leukotrienes, the principal chemical mediators of inflammation, and the fraction of nucleotide of placental extract suppress the chemical mediators of inflammation derived from plasma. So the complement, the kinase, the coagulation factor, all these are prevented. And ubiquitin of placental extract accelerates healing process. It increases collagen synthesis and improves tensile strength of the healing tissue also. Also causes tissue regeneration, wound healing, has significant immunotropic action involving both humoral and cellular immunity. See, we all know that placenta has such a big role during pregnancy, and that is what we are utilizing, in this particular condition, so that, all the factors which are helping the baby can also help here to produce a baby by not causing sequelae of the inflammation. Next. So the drug has comprehensive anti-inflammatory action that's offering better control of PID, because the PDRNs, which inhibit pro-inflammatory cytokines, the components act by entering the microbes. So what they do is, the PDRN, I told you, it produces VGF-EF, that is vascular endothelial growth factor. And we all know that how bacteria act. What they do is, once they enter a tissue, they form what is known as a biofilm. So this biofilm has to be damaged. Otherwise, no antibiotic can even enter the bacteria to kill it. So PDRN helps in damaging the biofilm, so that the bacteria can be reached by the antibiotics, so that it can exert its bacteriostatic or bactericidal or fungistatic or fungicidal action. And it also stimulates growth factors, I told you, the VGEF, and it also induces the placental growth factor, then the fibroblast growth factor, and transforming growth factor beta. They all help in tissue repairing. And drug depicts which disrupts the biofilm bacterial infection is very good, so that the antibiotic can reach this. And nowadays we are using more and more of these sort of things, isn't it? When in urinary infection, are we not using the cranberry juice and the hibiscus extract to disrupt the biofilm? The same way, here the placental extract also disrupts the biofilm, so that the antibiotics can act on the bacteria. Next. So antibiotics versus biofilm, this is what I already told. Because when there are antibiotics given to treat Neisseria gonorrhea or chlamydia infection, the biofilms will prevent them from reaching the antibiotic from reaching the organisms. Because not only from altered pH, osmolality, nutrient scarcity, everything, all these are blocked by the biofilms. So the biofilm matrix gives the additional resistance power to bacteria. So you have to use something so that, the biofilm is disrupted and the antibiotic resistance does not develop. That is what we are talking about. Next. Next slide. So biofilm formation is thought to be a mode of antibiotic resistance so common in PID, which I already mentioned. And peptides also exhibit biofilm breaking activity and prevented the formation of biofilm by bacteria. Next. Next. Now, NADPH of placenta, which I already told, it is a anabolic factor. It improves the anabolism, and anabolism means growth, and growth means more blood flow. So more blood flow means there has to be nitric oxide. So NADPH in placenta, it acts on local L-arginine, which is available in the body, and the nitric oxide synthase is mediated, and nitric oxide is produced. And whenever nitric oxide is produced, the blood flow will increase because angiogenesis occurs. So whenever angiogenesis occurs, this is very, very important because nitric oxide synthase, which we are also talking about, nowadays about dydrogesterone, increasing the nitric oxide synthase and improving the placental vascular formation, so that the syncytial trophoblast can invade more and more into the myometrium, so that the blood flow to the baby increases. So that is another action of dydrogesterone. The similar way, NADPH also is acting the same way. So nitric oxide induces vasodilatation, promotes blood flow and angiogenesis. Next. So now look at the biological action. In placenta, that is the placental extract, there are peptides, which has a debridement action, promotes better blood circulation. Ubiquitin is collagenase activity and improves tensile strength of the healing tissue. And CRF, that is the corticosteroid releasing factor, body's own anti-inflammatory mechanism, so that the steroids are produced by the body and which will be anti-inflammatory. And the nucleotide like NADPH, nitric oxide mediated vasodilatation, promotes blood flow and angiogenesis, and pDRNA inhibits pro-inflammatory cytokines and stimulates the growth factor. And amino acids are chemotaxis inducing factor, so that the macrophages can reach the tissue and then take away the debris. Next. Next slide. So these are all the studies, all are from our own country. Pramila and Kavya D. Sharma from Chilwamba Hospital, Mysore. They have done a study where 50 patients of PID within reproductive age group of 20 and 45 years were recruited. And diagnosis of PID is always clinical. And they were divided into two groups, 25 in one group and 25 in another group, where 25 were given injection placentric daily for 14 days, and 25 patients were given the macrolide azithromycin 1000 milligrams. It's a single dose and repeated after 1 week. They were followed up for 2, 4, and 12 weeks after starting the treatment, and the results are, next slide. So when you look at the conventional, the complete remission in 2 weeks was much more in women who use the placental extract, and recurrence also is much, much less. So conventional anti-inflammatory and proteolytic enzymes leave the therapeutic gap. So placentic injection is expected to fill up the gaps adequately. It leads to marked relief in symptoms than compared with antibiotic therapy alone. As placentic decreases adnexal inflammation to significant level, it can be a good option, so especially to reduce symptoms and sequelae of pelvic inflammatory disease. Next. We also have a study, way back in 70s by Dr. Purandare, which also we will be showing. That means the placental extract was being used since those days. That is what I told you when I talked about placentrix, which we have been using. A comparative study to evaluate the efficacy and safety of injection placentrix as compared to conventional therapy in pelvic inflammatory disease. This is from Amritsar Government Medical College. They had 90 patients. They divided them into 3 groups here, 30 each. One group was given only placentric, one group was given only doxycycline, one group was given a combination. And it was given for 14 days. The final evaluation was done after 14 days, depending upon the clinical global impression scale, Next slide. The results were, next slide. You look at the group 3, the excellent response, where you combined the doxycycline with placental extract. And poor response according to the same scale, where only doxycycline was given. So the conclusion is placentrix injection given from day 1 of diagnosis of PID is better option for treating PID and in preventing complications of PID as compared to conventional antibiotics alone. Next. So this is a clinical endorsement again by, it's an article by Nutan Agarwal and Etra from Alka Kriplani also. It is from Indian Medical Association volume journal. and 100 patients were recruited. There were 50 in each group, and one group was given again doxy plus Placentrix, the other group doxycycline alone for 14 days. And then, they looked at 2 weeks, 4 weeks, and 12 weeks for the recurrence of symptoms and the relief of symptoms. Next. So the core treatment with Placentrix, PID, provided a much higher remission rate of 68.2%, whereas only antibiotics, 18.2% only remission. So adding Placentrix is much, much better than giving only antibiotics alone in pelvic inflammatory disease. Next. Next slide. This is again a clinical efficacy, same by the same author. The abstract shows combination of Placentrix injection with the antimicrobial therapy is a better option for treating pelvic inflammatory disease than only antimicrobial therapy. So Placentrix decreases adnexal inflammation to significant level in comparison to antimicrobials alone. It can be a good option, especially to reduce the risk of tubal damage, infertility, and formation of adnexal mass. So overall, group 1 had better as well as sustained effect of therapy on relieving dyspareunia, fornix tenderness, and uterine restricted mobility, which was statistically significant. Next. So again, a comparative study of same Placentrix and conventional therapy. There also they found marked reduction in sign of adnexal tenderness in the Placentrix group as compared to the conventional antibiotic alone treatment. The P value was very, very impressive. Next. Now, this is the paper I was alluding to, way back, they have used, Dr. C.B. Purandare and B.N. Purandare have used it, and they found that placental extraction injection is therapy in tubal block. So we didn't have, the tubal cannulations and no hysteroscopy, laparoscope were available those days. So we had to treat them like this. And then, the results in cases with symptoms of pelvic inflammation were next slide. This is in 1970. Next. What they found was the injection therapy with placental extract deserves a trial in tubal block prior to subjecting the patient to major abdominal operative procedures, as our experience indicates. Very favorable results in those days. We used to call it sterility. Now, of course, we call it only infertility in cases and tubal block and menstrual irregularity. Because of the infections and inflammation, in chronic pelvic inflammatory disease, apart from the fertility problems and the chronic pain, they also used to, because the blood flow is increased to the ovaries, there used to be a early maturation of follicles. So naturally, frequent cycles, heavy cycles also used to be a problem. And Placentrix really used to treat that also, And when you look at their study, way back in 70, imagine, 32 patients were treated, tubes opened out in 24, out of which, that means 75%. 2 people became pregnant naturally, and no effect was in 8 patients, that means 25%, and no pregnancies occurred. Next. So we can still try this, and this is a new study, Kalpana Khanderia and Manish Pandya, where they have found that Placentrix is very useful in follicular cyst also. That is a single follicular cyst. We all know follicular cysts are physiological, but because of the scans, nowadays, even if there is ovarian cyst of 2 or 2.5 centimeters with clear fluid in it, it can be an unruptured follicle, But our people are so enthusiastic, they want to go in and do a laparoscopic excision and reduce the ovarian reserve. In view of that, we can still use Placentrix injections and try to see that the follicular cyst disappears. Some people give cyclical hormones, for 3 cycles, 4 cycles. Actually, that is all not required, They may disappear on their own. But if the patient is very, very worried, we can use this placental extract also, along with painkillers, if they have pain, that is. And they have done a prospective study on 300 patients between 20 and 35 years, and they found that 3rd day of the first menstruation after completing the course, and they found there was absence of the cyst. Next. This is from our Indian Gynecology, Indian Journal of Obstetrics and Gynecology, The pain also decreased. 95 patients were cured after the first course. Another 5% were given another medicine. So Placental is very effective in the treatment of functional ovarian cysts. So instead of going for a diagnostic laparoscopy, we can as well give them the Placental injections. Next, I have no experience in using it in follicular cysts. Sorry. So unexplained infertility, monofollicular cysts, when you are doing ovulation induction, and it is supposed to help even in implantation because of the growth factors. Just now I was alluding to all the growth factors, isn't it? And growth factors will increase the rates of implantation also. Next. So the implantation is because of growth factors, cytokines, adhesion molecules, integrin, which is an adhesive molecule, nitric oxide, and then corticosteroid releasing factor. And the local factors are directly involved in attachment, penetration, and embedding of the blastocyst into the maternal decidua. Next. So they induce growth factors, and growth factors will interact with the receptors and are responsible for attachment of the blastocyst. And placenta contains, like I said, NADPH, which will release nitric oxides and from L-arginine. And then the PDRN, it will release the VGEF, that is a vascular endothelial growth factor, which will increase again the circulation. So naturally, it is not a hormone therapy. So you need not restrict it, and there won't be any side effects also. So it provides fibronectin-like peptides. So they will improve in the adhesion molecules via integrin receptors during implantation. Again, I am not a fertility specialist. I would like if any fertility specialist has used it, what is their experience. Next. So in clinical practice, 1 ampoule every alternate day. I give it for 14 days. Here it is said 10 days, but I give it for 14 injections. That is 28 days. You can give it in PID. Follicular cyst less than 5 centimeters. So anything which is more than 7 centimeters, actually we treat it as a pathological problem. And of course, female infertility, unexplained infertility, PCOS. When you are inducing ovulation, you can still use it along with IUI. And a persistent PID, you can continue using it at least to reduce the pain. Next. So the advantages are anti-inflammatory effect due to inhibition of chemical mediators of inflammation, combats infections and reduces the incidence of infection, relief from PID-associated pelvic pain, and it induces, it helps the debridement and collagenase activity, and it has a biofilm disruptive property which will prevent antibiotic resistance, non-toxic, non-antigenic, and strong healing tissue prevents excess scar formation. Next. So conventional antibiotic therapy alone does not provide maximum relief of symptoms and sequelae to PID. There is a therapeutic gap in management of PID and which needs to be filled, and that is where placental extract takes over. So co-treatment with placental extract along with antibiotics which we are giving can maximize the therapeutic response with minimal chances of antibiotic resistance and PID recurrence. And route of administration intramuscular. It should not be given IV. Deep injection into gluteal muscles, gluteal area, that is upper outer quadrant of the gluteal region, up to maximum 10 to 14 injections found to be effective even in the presence of pus, serum, blood, and slough. Need not be restricted by the menstrual cycle since it is not a hormone. Next. Thank you very much. If I have any questions in the chat box, I'm ready to answer them.
Yes, ma'am, I am checking out if there is any question. Ma'am, till now we have not received any question from anyone. So, so
Yeah.
I'm just waiting. If any questions come, I will definitely let Anil sir know. Okay, I'm just refreshing the page, but I haven't received any questions till now. If there is any question, you can just write in the comment section. Ma'am, we haven't received any question till now.
Okay, then we will call it a
Fine.
day. Okay, we
We'll
can
call it
wind
a day
up.
then.
Yeah.
Yeah. Ma'am, I'm Minesh calling from Corona Remedies. I
Okay.
just want to understand, ma'am, since last 1.5 months we are promoting this product, ma'am.
Mhm.
In PID also, when we are promoting, I'm not talking about infertility, ma'am. PID
Okay.
only.
Okay.
When we are promoting in PID, some doctor ask us that exactly which is the ingredient of this placental, this placental extract, which is responsible for alleviating the symptoms of PID. Ma'am, there are
All-
many actually.
No, there are all the ingredients, from CRF to NADPH to PDRN to
Fine, ma'am.
peptides. All the ingredients which I mentioned, they all help. You understand?
Okay.
So there should not be a problem because each factor of the placental extract has a particular action. So
Right,
all
ma'am.
these factors will act.
True, ma'am. True. Thank you. Thank you so much, ma'am. Actually, what happens when some doctors ask our medical representative, issue is what they keep mum.
They don't know about it. Actually,
That is
they
right.
should also have been included in this audience,
Sure, ma'am. Sure, ma'am. Thank you so much, ma'am, for your all valuable, I'll say, time in this weekend. And I think we have Pushparaj more than 160 plus participants, ma'am.
Oh.
Sir, we are now, we have 300 more participants.
160 plus was in between when you are presenting, ma'am. 300
Yes,
plus. So I'll congratulate you, ma'am, and definitely I'm thankful to you both. So thank you so much, ma'am, for all your valuable time as well as the contribution, ma'am. Thank you so much. I think we'll call it a ma'am then.
Oh.
Okay, thank you so much, ma'am. Yes, yes, sir.
Go offline then.
Okay, sir.
Thank you, Pushparaj.
Thank you, ma'am.
Thank you.
Thank you, Dr.
Thank you so
Anil.
much, ma'am.
Thank you, Nimesh bhai. Thank you, Sonia madam.
Thank you all. Thank you.
Thank you, Srini ji.
Thanks to ma'am also.
Vijay. Thank you so much, dear.
Thank you, madam. Thank you so
Bye.
much, madam.